Hello, I'm Carrie. I've worked with Rissa and Sarah, and we will be discussing the Prader-Willi syndrome as the topic of this video. Our case is about a mother named Paula and her child who has PWS. We will first sum up the case, and then we will discuss some issues related to PWS. So to begin with, our story begins with Paula and her son. She's a 45-year-old mother who became pregnant with a gentleman who she is no longer with. The baby was then born at 35 weeks gestation and was genetically tested because it appeared that the baby was really floppy. Once she got the diagnosis, she felt very lost and very confused. She felt like the nurses were not helpful to her at all. They lacked compassion, they lacked the eye contact whenever they were in the room with her, and she felt like they pitied her and didn't care about her diagnosis for her son. As a result, she felt very unprepared and unsupported with her with the nursing staff. So at 8 weeks old, it was decided that the baby would go into foster care because she was unable to care for it. She became very depressed during this time and had a really hard time coping with the diagnosis of her son. Eventually, her doctor did connect her with a PWS association, and she met a woman named Karen who gave her a lot of support. She then decided, along with Karen, that she could do this, and she decided to take her son out of foster care. Over the next year, she did a lot of doctor visits and making sure her son was growing in the right way, and now she believes that her son is a typical 4-year-old who walks and talks and plays and does everything normally. She feels like she worked very hard to get where she was at, but if she would have had support from the beginning, it may have not allowed her son to be in the foster care at all. I'll give you a little brief background now on the Prader-Willi syndrome. It's a complex genetic disorder affecting appetite, growth metabolism, cognitive function, and behavior. It was discovered in 1956. The hallmark characteristic of this is the individual is always hungry and wants to eat because they can never feel full. It is one of the most common genetic disorders that causes life-threatening obesity in children, even though it is considered a rare disorder. PWS is the result of a spontaneous genetic error abnormality on the 15th chromosome near the time of conception for unknown reasons. It is not usually inherited. It is not usually an inherited condition, but a spontaneous genetic error.
All right, so we're going to talk about the 4-year-old baby of the story who has a PWS. PWS is a multi-phase syndrome from phases 0 to 4. Phase 0 is in utero, and phase 4 is later into adulthood, where the
Alright, now we're going to discuss some questions that people have for the story. The first question is, the mother of the story said she felt very alone and scared, and the nursing staff didn't discuss the diagnosis with her. What might be some reasons for this? Are there any guidelines for delivering bad news that exist locally or are defined by your professional body? So we'll go with some answers with that. The mother of this child felt like she was really alone and lacked a lot of support based from her family and her nursing staff. The father was not involved with the infant at all, so she lacked the support of having a partner along with her. The nurses on the unit were really afraid to look her in the eyes, and she felt like they pitied her and felt bad for her and didn't really give her the support that she had needed. When she did receive the diagnosis, she felt like the nurses ignored the diagnosis and didn't talk about it with her, and that was another thing that contributed to her feeling like they pitied her. After that, when she did decide that she did feel like she could take care for the infant, they immediately jumped to her sending the baby to foster care rather than discussing with her why they think that she wasn't able to care for the infant. Some protocols that I feel should be in place for telling a patient bad news is looking the patient in the eye when you're talking to them, letting them know that you're there for them, and being honest about the diagnosis, telling them everything that they want to know and everything that they will need to know. I feel like avoiding false hope would be a really good thing to do, and periodically asking the patient if they have questions or concerns, and allowing them to have a lot of time to discuss the diagnosis and be able to ask the things that they need to. And looking for different protocols for this, I was able to find a 6-step protocol for communicating bad news from the American Medical Association. To begin with, you get started. You start to, as the practitioner, you need to get the information you need, everything. Make sure that wherever you're going to tell the patient, it's a good environment, it's quiet, it's effective for communication, and you're allowing plenty of time for communication, not saying, okay, well, here's your diagnosis and I'm out of here. Your next step would be to determine what the patient already knows about their diagnosis. Ask them the questions like, what do you know about this? What can I tell you about it? And how do you think your health is? You should also then, the next step be to determine how much information the patient wants to know. Ask them, do they want to know everything about the diagnosis, or do they want to just hear the bare minimum? The next step would be then to share that information, followed by responding to how they feel about it, showing that you're there for the person and that you're able to answer any questions that they do have. And then lastly, you want to plan for their future. Give them ideas for what they're going to be doing with this diagnosis and their treatment plan, and then allow some time for follow-up too, so that that first initial diagnosis can be really hard, and you want to make sure that you can go back after the fact and talk to them and say, this is your diagnosis, and do you have any questions now after the shock of everything?
Increased appetite is, they no longer have that. So our child in this story is in phase 2, which ranges from ages 2 to 8. And in this phase, they have a weight increase, and the child starts to cross the percentile line in the normal weight curve. Here, however, the child does have an abnormally increased appetite, but it is not insatiable. And learning and behavioral problems may start to appear in this phase. So we're going to describe the condition of PWS right now. So it is a genetic error that results in the lack of several genes on one of the individual's chromosome 15. It is normally the chromosome that is contributed by the father. In about 70% of the cases, the genetic error is spontaneous deletion of the gene. Other genetic errors are a maternal uniparental disomy, where both copies of chromosome 15 come from the mother. Or the error can also be from imprinting defect, where the father's chromosome is present, but it just doesn't work properly. In our story, the child has a genetic error of disomy, where he started out with 3 chromosome 15s, 2 from the mother, 1 from the father, and then the father's chromosome 15 was lost, and the child ends up with 2 chromosome 15s from his mother. The genes that have the genetic error play a role in regulation of appetite. They have a flaw in their hypothalamus, which is where you register feelings of hunger and being full. PWS isn't fully understood, but we do know that those with the condition never feel full and have a continuous urge to eat that they cannot control. These individuals who do have PWS need less food than those who do not have this syndrome, because their bodies have less muscle and tend to burn fewer calories.
Okay, so now we're going to talk about presenting symptoms of PWS. This includes insatiable hunger and a slowed metabolism that can lead to excessive eating and lifelong threatening obesity. Life-threatening obesity. Also low muscle tone, which is why the babies when they're born are really floppy. Motor development delays. Short stature, which is treated with growth hormones. Incomplete. So our next question was, how would you find further credible, reliable information about this condition, and where would you find information for parents? The first source would be the Prader-Willi Syndrome Association, and this website is also suitable for parents, but there's a lot of information geared toward parents, physicians, and just the average person. Also the Mayo Clinic and the Genetic Home Reference, which is powered by the NIH, would be good for clinicians, as well as the Foundation for Prader-Willi Research. The next question was, imagine you are teaching an undergrad nursing student cohort. In what areas of the curriculum would you help students to develop competence in supporting members with a genetic condition? Some of the areas would be in pathophysiology. Students would gain the basic knowledge about these genetic conditions, including etiology, clinical manifestations, the disease course and treatment. Nursing care of the family, students could learn therapeutic communication techniques that would aid them in supporting not only the patient with the disorder, but their family, and how the family could cope with having someone with a genetic disorder in their family. Also in the mom-baby area, students can learn how to care for parents who have a newborn with a new diagnosis, of a genetic condition and how to direct parents to appropriate resources to learn more about their child's condition and what to expect in the future. And lastly, in PEDS, students can learn to tailor their techniques to care for children with different cognitive and or developmental delays that can be associated with these conditions. Sexual development and an average IQ of 70, in addition to learning disabilities and social and behavioral problems such as OCD. And they need a constant routine. Some stats about PWS. The incidence, it occurs in males and females equally, and as well as an equal occurrence in all races. It occurs approximately 1 in 15,000 births. In the past, many of those with PWS died in adolescence and young adulthood. But now, with more, what's the word I'm looking for? More emphasis on preventing obesity. They are keeping people alive longer, and they have more close to a normal lifespan. There are no exact numbers on morbidity or mortality. However, complications due to obesity and behavioral problems are the major contributors to morbidity and mortality in people with PWS.
So now I'll talk about the impact PWS has on the individual. Those with PWS, if they have help, they can do many things normal peers can do, like go to school and get a job. However, they will also need to have locks in place on all food storage areas in the home so that they can't get into the food. This also includes careful watching in school and in work to make sure they don't get into more food than they need. They need a significant amount of support from their family, school, and work to be all understanding of their condition. To improve the quality of life of individuals with PWS, psychotropic drugs and synthetic growth hormone can be used. Currently, research into the disease hopes to discover new and better ways that can lead to more independent lives for those with PWS.
All right, our next question is, what do I think that the lived experience of this condition would be for the affected family and their affected patient and their family? And how do I think this condition would affect the parents, the grandparents, and the siblings? You know, I feel that the condition would be really difficult to get. You know, to hear that your child has a genetic disorder would be really hard, and I would not know what to react to that. It makes me think that the parent would have a lot of questions for the future and questions about their ability to raise their child, like we saw with the story. As I stated, I think parents would be scared and maybe feel guilty with the diagnosis. Our story didn't have any grandparents in it, but I feel like they would be also feel like helpless to help their child cope with their children's diagnosis, and also have some guilt themselves that they were carriers. As for siblings, I feel like they could be a little jealous that the new infant is getting all the attention and not them.